So we have done some work of how do you maximize the ability to get volume or load during a chemotherapy within each cycle, 2 or 3 weeks long, and over like this whole block of 12 weeks, 16 weeks that you're doing, knowing that consistently the pattern typically is that people feel not that well, 2 to 3 days. It sort of depends. It's individual, but there's times after your chemotherapy, you don't feel great for a few days. Then you start to feel a little bit better. And that's the whole idea of chemotherapy, is that your body's recovering enough, white blood cells, all the other factors, in time to get another dose. I mean, that's what they're waiting for, is for you to kind of recover enough so they can give you more. And so we've done some work called chemotherapy periodization, where we try and build up the load. So the week after your chemotherapy, we sometimes reduce the intensity, but try and keep the amount of time the same, for example. And then we use that opportunity of you kind of recovering to try and load more exercise on. So increasing the intensity over those 2 to 3 weeks in between, knowing that then, okay, the next cycle happens, we kind of go down a little bit more of the week after and kind of build back up.
The number of cancer survivors in the U.S. alone exceeds 15.5 million, a figure expected to double in the coming decades. The general role of exercise for our health and well-being is well known. But what about for the individual who's in the midst of or the tail end of the cancer journey? Does it play an important role there? And if so, in what ways? Why isn't it generally emphasized as part of the treatment protocol? And what recent advancements in the research might be changing that unfortunate historical trend? Today's guest, Dr. Kristin Campbell, has spent her career diving into these and related questions. She holds a PhD in exercise physiology, a license in physical therapy, and is a professor at the University of British Columbia, where she holds an appointment in the Cancer Control Program. Her research focuses on the role of exercise in cancer prevention, rehabilitation, and survivorship. I had an opportunity to hear her lecture in person recently and was very happy when she agreed to join us here on the podcast. I have a feeling this is one of those episodes you're going to want to share with friends and family. Thank you for joining us here on the Catalyst 360 podcast. I'm your host, Dr. Brad Cooper of Catalyst Coaching 360. And before we welcome Dr. Campbell, a quick item of note for those looking to pursue a career as a health and wellness coach, or potentially current coaches who are looking to enhance their skills. As many of you have heard, Fortune magazine recently recognized Catalyst Coaching Institute as the #1 health and wellness coach training program. If you're looking to pursue your MBHWC approved certification, please don't wait to register if it's a priority. We have only 2 more cohorts kicking off the remainder of this year, and they are filling earlier than they ever have before. And if you're already a coach, Catalyst Coaching offers the Rocky Mountain Coaching Retreat and Symposium in Colorado this September. Details for all of these are available on our institute site, catalystcoachinginstitute.com, or reach out with questions about either one anytime. Results at catalystcoachinginstitute.com. And now it's time to tap into the latest guidance on exercise and the cancer journey with Dr. Kristin Campbell on the latest episode of the Catalyst 360 podcast. Dr. Campbell, pleasure to have you. Got to see you speak at the seminar here at Colorado State University a couple months ago. Loved your stuff. Fascinating information. Thank you for joining us.
Oh, thanks so much for having me.
And we will chase some rabbit trails. A big part of what you spoke about that day was exercise and cancer. And it seems to me, as I was thinking about this, there are so many different variables with cancer in terms of histories, current status, where they are in the journey. It seems like your research would be almost an impossible pursuit. How have you gone about narrowing the almost unlimited variables to identify some meaningful clinical guidelines?
Yeah, it's a great question. When I teach the undergrads, I say cancer is 100 different diseases, sort of kind of packaged under this umbrella that, cell cycle is disrupted and tissue kind of grows unchecked. And so I think where we've tried to tackle things is a lot of the research really started with some of the more common types of cancer. Okay. So breast cancer and prostate cancer are where most of the research has happened, because those are the 2 most common cancers in men and women in sort of more industrialized countries. And that's where, there are more people that have experienced that. So that's where things have started. And then we've tried to kind of extrapolate that. What do we know about treatments in general that are provided, like chemotherapy or radiotherapy? And how does that impact physiology, mood, psychology? And how do we then how much can we apply to other cancer types? Like this is the common thing that most people have, such as cancer-related fatigue. When they have these type of treatments, we extrapolate it. But I think the nice thing is that now we have the fundamental understanding of safety, that exercise is possible during chemotherapy generally. So then it's allowed people to start doing projects in other types of cancers. So I think having that kind of base guideline that's then kind of given permission for people to try it in other cancer types. So we're getting more and more information that is more specific to how do we use this in prehab around advanced lung cancer, those type of things.
Right. Okay. That makes sense. You talk about the 3 Ps in terms of figuring out the right approach: precision, personalization, and pragmatic. It's got to make sense. Can you walk us through each of those? Why do they matter? For the personal, I have a feeling people are going to be sending this conversation to a lot of friends and family members who are looking for answers or ideas or just some help. So can you give us some context around those 3 Ps and why they matter, how someone independent of you could kind of figure that out and chart their own course or work with their physician on that course?
Yeah, the 3 Ps, I honestly think, to your question, is more around the researchers. I was trying to figure out how we package things and what's the way forward. So things like personalized or precision is very hot in the oncology space, where these are the type of medications that we're trying to personalize for different tumors, knowing that the biology of tumors is really, the understanding is expanding. So now it's like, it's more, maybe it isn't the type of tumor, like a breast cancer or prostate cancer, for example. They have unique features in and amongst themselves that are more like each other potentially. So they're using the biology. And so that's precision. Like, how do we use the right exact target if it's a HER2 positive cancer, for example, or something that has cross angiogenesis markers, things that are kind of cancer type agnostic, but just cancer specific. So there's a lot of interest in that. I guess when we talk about the oncology space, like everything's precision.
Right.
So if we want to have the same conversation, can the exercise oncology space use the same language? There are some researchers that are definitely leaning into that, because then you can have the conversation at the oncology meetings or with oncology teams, because that's the world they're living in, to try to meet them where they're at.
Yes.
On an exercise standpoint, though, I don't think that we know enough to say that, this type of hit resistance training is going to be the thing that's going to be knocking down mTOR and this and that and the other. And that's the precise type of thing that's going to be most beneficial for that tumor. There's interest in that, and I am happy people are pursuing that. But that's one approach. The personalized is kind of the middle piece, and we get a lot of pushback from a lot of our research that the prescriptions are too generic. They're not personalized enough. I would argue back to that yes, research studies are a bit constrained. They're 2 days or 3 days a week. We're using heart rate reserve targets to try and standardize something to be able to report the effect. But anyone that's given a heart rate target to someone, like, that's been personalized for them. They have some sort of baseline exercise test or some sort of discussion that even within a very tight research study, prescription, that has been personalized. So don't give me this like generic prescriptions don't work or it's not personalized enough. I push back on that. So I think what we can take from that is, yes, the studies have shown us that this type of activity 3 times a week in these heart rate ranges has been beneficial. And of course, that's if you were going to apply that as a clinician or working with, or if you are someone who has the cancer diagnosis yourself, you're going to personalize it to yourself just by thinking, well, how does this work for me? That type of thing. So that's where I think all prescriptions have been personalized, even if we get some slack for that.
Well, and
the last piece is,
go ahead.
And the last piece is pragmatic. Like, at the end of the day, we want people are not hearing about the potential benefits of exercise to help manage symptoms of common cancer treatments and help people improve their quality of life and return to kind of previous activities, leisure time activities, work activities. They're not getting the message that exercise could be part of supportive care. So what is I don't want to say bare minimum, but what is some pragmatic way we can actually get this information to people's hands? Yes, would I love an oncology rehab program like pulmonary rehab or cardiac rehab at the hospitals all around the world? 100%. And if we get there, great. But there's a lot that has to happen before we get there. So what can we do now that's a really pragmatic approach? It may not be the perfect personalized or precise exercise prescription, but some people are getting at least something that should have a benefit.
Yeah. You make me think. So we have these 4 cornerstones that we're talking about all the time: move, fuel, rest, and connect. And what I love about those phrases is they are personalized by the hearer. So it's move. It's not run a marathon. It's move. It's not do CrossFit. It's move. It's not hike with a backpack. And same with fuel. It's not do this certain thing. It's fill your body with what's valuable. And we all know pretty much what connect. That's relational. Some people more, some people. Anyway, it reminds me of what you're saying there. It's move. We know move matters. We know that benefits the journey through chemotherapy. We know that benefits, we'll talk a little bit about pre-cancer. More than 90% of it is move. 10% of it maybe is where your heart rate is, what your quality, quantity, et cetera, et cetera. Am I hearing that right? Is that where we are, at least today with research? We're going to try to get more specific over the next year, 10 years, et cetera. But at this point, move. We need to move.
100%. And that's the first. So there are international exercise guidelines for people living with a cancer diagnosis. They were developed in partnership with ACSM and the American Cancer Society. And the first thing is move more. Moving more benefits nearly everyone.
Beautiful.
There are situations where people have physical impairments or limitations that may need a rehab professional to help them activate that ability to move more. But fundamentally, it is move more. Then if that's, you've kind of got into the groove of that and you're feeling like some benefits, then let's talk about symptom management. If you are having fatigue as your main challenge, all right, when we look at the literature, it looks like this amount of activity, which is sort of 20 to 30 minutes, 3 to 4 times per week, that's starting to show a potential benefit consistently for cancer-related fatigue. So that's where either that can be something you shoot for or work with someone to help you figure out how that would work for you. And then if symptom management's, you're doing well with that, the activity you're doing is going well, and you're interested in doing more, that's when the final piece of those recommendations is, okay, let's aim for 150 minutes per week, 2 days a week of strength training to get the general health benefits of exercise, decrease your risk of cardiovascular disease, diabetes, the long list.
Stuff. Yep.
It's move more. Then if we can do some symptom management stuff that's a lower bar. And sure, again, maybe once you've finished your cancer treatment, or if it's working well for you, you're tolerating treatment well. Yeah, sure. Let's aim for those whole body health related benefits. But move more is the starting point.
And so everybody's chemo schedule is subtly different, but let's just say that you're going through it every 3 weeks, 3 or 4 weeks. Do you recommend, or do we have details yet on, I'm almost thinking of the person that's tapering for a big race. So a month out, you're running high intensity, high quantity, high quality, and then 3 weeks out, a little less quantity, but same quality. 2 weeks out, really decrease that quantity. And then the week of the race, you're really light. Is it a similar type of concept, except I guess that 4th week out, you would be just coming out of chemo. So that might be even less. That'd be like post-race. Is there any connection between those two concepts? Or are you saying just do your best to get that 20 minutes or more? Again, are we trying to create some ups and downs through that journey, or is it just try to get out there?
That's a great question. And so we are, an exercise podcast. So, I am an exercise physiology trained researcher. So I do love periodization and understanding that concept and kind of this readiness to train. How are you feeling? How do we match those things? So we have done some work of how do you maximize the ability to get volume or load during a chemotherapy, like within each cycle, 2 or 3 weeks long, and over this whole block of 12 weeks, 16 weeks that you're doing. Knowing that consistently the pattern typically is that people feel not that well, 2 to 3 days. It sort of depends, it's individual, but there's times after your chemotherapy, you don't feel great for a few days. Then you start to feel a little bit better. And that's the whole idea of chemotherapy, is that your body's recovering enough, the red, white blood cells, all the other factors, in time to get another dose. I mean, that's what they're waiting for, is for you to kind of recover enough so they can give you more. And so we've done some work called chemotherapy periodization, where we try and build up the load. So the week after your chemotherapy, we sometimes reduce the intensity, but try and keep the amount of time the same, for example. And then we use that opportunity of you kind of recovering to try and load more exercise on. So increasing the intensity over those 2 to 3 weeks in between, knowing that then, okay, the next cycle happens, we kind of go down a little bit more of the week after and kind of build back up. So that has been some of the challenges, is people want to overlay the usual exercise prescription that you would use for anyone. It's kind of this linear improvement. And with chemo, like that's the anticipation that, we can keep, going to linearly improve. The challenge with chemotherapy is that people are getting more and more symptom burden over time. So we're trying to ramp up the exercise while people are feeling worse and worse. Right. And so that's kind of our approach we've tried to use to try and use the timing that we know is happening to the best benefit, and give people the opportunity on those days they feel terrible to kind of use that move more, like whatever you think you can do today, that's the thing. And I think that helps to keep people more engaged, because when you're not feeling well, it's harder to engage in activity.
Oh, absolutely.
But typically we hear that after they, come to the fitness center with us, for example, or gone out for a walk, they feel better even when they're not feeling great. So we've used that kind of bad day or post chemotherapy time to kind of ramp things down. Let's keep engaged. Let's keep moving. And then once you're feeling a little bit better, we're going to load up again.
Well, it almost seems like it would be reverse build, like you're starting at the highest level. And then as each session, whether we're doing 3, 4, 2 week intervals, you can tolerate less. In fact, I think I remember during your lecture, you talked about one of the biggest benefits is allowing these individuals to take in the full round of chemotherapy, because so much of the critical nature of it is getting beyond, I think you said 80% or somewhere in that range. And the exercise is one of those things that allows you to get to that critical point. You don't pull the plug at 65% or 67%. Am I remembering that right? And is that part of this whole equation we're trying to figure out?
Yeah, that what you're speaking about is that chemotherapy completion rate. Yeah. And generally, if you get 85% of the treatment that your oncology team planned, then that has been linked to better survival outcomes. It differs by some different tumor types, but generally that's kind of like, for most in general, that's what it is. There's some research now, and it's not definitive yet, that being active during your chemotherapy helps you to sort of tolerate the treatments a bit better and are more likely to get to that 85% or more. And so there's a lot of interest in that, because when we talk about exercise for oncology and symptom management, the oncology team, their main focus is survival. So they are used to, how does this, or treatment tolerance, like they want people to have this 85%. So a lot of interest on the exercise side is, well, how can we meet the oncology team where they're at and talk to them in the language that they are talking about? So completion rate, they're like, oh, okay, now I'm interested in talking to you. Feelings of well-being and improvements, like none of the oncologists dislike that. They think that's right. Great. They really are
priority one. Exactly.
But for having a part of the cancer treatment and part of the care model at their center that costs money, that, that's the kind of thing. Well, what kind of metrics are you showing us that makes a difference to the bottom line? Is the wrong answer, because that's not really how cancer care is delivered. But is this going to have a treatment improvement? Then that's something they can go to their administrator team with, or their, the funders of whoever's kind of holding the bag to say, this is the kind of thing that will allow better survival for our patients. So that's the gold standard. We have done a review that was published several years ago, I think 2019, that looked at that, and it was very much unclear. Some studies showed a potential benefit, some didn't. A lot of different metrics were used, likelihood to get the next cycle, all sorts of different things. So there's been a real move in the last 5 years within the field to kind of standardize some of that. So some great work from an NCI collaborative group called INICTO that's trying to understand, like, how do we do chemotherapy completion rate consistently so everyone's using the same metric? And then testing this out where that is the primary endpoint. all the studies we looked at, it was a secondary exploratory endpoint. So interesting, but these trials now are powered for that. So I think in the next 2 to 3 years, we'll have more information on that, but that's something that's really interesting. So if you're more likely to be able to sustain the treatment, then that might be where the oncologists are more interested in hearing about it.
Right. That makes perfect sense. I'm wondering, are there, and maybe you're not testing for this or assessing for this, but are there pre-treatment, pre-chemo lifestyle patterns you've noticed that, Joe he never exercised ever, and it's really tough to get him, or he's not successfully implementing this pattern, but Sally, she's always been a hiker or a walker or a runner or whatever, and she prioritized it prior and was able to continue. Do you see any of those kind of trends of what you bring into the cancer journey is what helps sustain you in the midst of that cancer journey?
That's a great question. And it's kind of unfortunate too, because you can't change that after the cancer diagnosis. You're stuck with what you're stuck with.
Right.
I think there's 2 things I would say on that. One, there is consistent observational evidence. So big cohort studies where they've asked people to self-report their activity, and a little bit more now with accelerometers, that those people who are more active prior to a cancer diagnosis do have improved survival for some different cancer types. The nice thing about that is they've also shown that being active after your cancer diagnosis also decreases the risk of recurrence from cancer and dying from cancer in observational studies. So big picture observational studies, mostly in breast cancer, prostate cancer, and some more information coming from some other types of cancers as well. So that's the good news. Yes, being active beforehand potentially is beneficial, but even starting to be active at that time point can have potential benefit. There are no trials at this point. So again, we're talking to the oncology audience. They are used to randomized control trials that are drug trials, and you can see survival curves. So the first trial that has survival as a primary endpoint that people have been randomized to exercise or not after their cancer diagnosis is in stage 2 and 3 colon cancer. They finished recruitment in December of 2023. And so within the next year or 2, we should be getting to that trial information. So that's a very big thing for our field. Everyone's very excited. It's called the Challenge Trial or CO21 trial. And the PI leading that is Carrie Kernier, who's based in the University of Alberta here in Edmonton, Alberta. And Edmonton's also in the Stanley Cup Finals. Go Canadian NHL team.
You're picking on my Avalanche now.
Okay, well, hey, everyone's rallying behind. There's been I don't think Canadian team hasn't won the Stanley Cup since 1993 or something. So Everyone's trying to get on board. Everyone, of course, has their own team. But so people are trying hard to can I get on the bandwagon?
So was that in the Gretzky years that they last?
Well, that would be when Edmonton probably last won it. I don't know who this. Now you're really showing how Canadian I am. I'm like, who was the last Canadian team to win the Stanley Cup? I couldn't tell you, honestly. I'll look it up before the end of this podcast.
That sounds good.
Okay. Where were we? Edmonton. Yes. So that's okay. So that is where there is a trial for that endpoint, but that's going to be one type of cancer, one thing. I think what we have seen consistently, which I think is really important on the survivorship standpoint front, is that I think we want to have people move more, but chemotherapy, radiotherapy, the surgeries, all these new targeted therapies and immunotherapies, they are challenging drugs. And some people react well to them and have limited problems. Some people have a lot of symptom burden. And I don't think there's a consistent pattern. I don't think that if you were really active beforehand, that all of a sudden your cancer journey is going to be like some smooth sailing. In a perfect world, It will be, and that's great. But there's just so much variability. So I think what I try to remind people is that moving more is important, and there's going to be times that it's a fit or not, and maybe activity, it's going to be really challenging for you, even if you've been an active person. You're just 100%. Doing your best around what you can. And exactly. I think the nice thing that we want to have maybe embedded in the cancer system is an exercise physiologist or a physical therapist or someone with that background who can kind of coach you through. Even if you've had prior activity levels, you kind of understand the biology of it all and how it all is supposed to work. Or if you're new to exercise, just having that coach to kind of walk you through, how are you feeling? How can we titrate it for you going forward? That being said, because I'm a researcher, we run exercise trials, and inevitably people that are more active prior to a diagnosis or more potentially in that contemplation stage, they sign up for our studies. So there is a lot of people that we are missing where exercise hasn't been part of their life beforehand. And some people take a cancer diagnosis as like a time to make changes. Other people, I mean, there's so much information, there's so much going on that, adding one more thing that's new to them is maybe not a top priority. So my hope is that we can at least get the information out there. They can see that potentially there's a benefit to exercise and either work with someone who can work them through it, or at least get that move more message, like just try some walks, just get going. It's hopefully, just see how it works for you.
Yeah. Topic for another day, but it sounds like that coach that's trained in intrinsic motivation and motivational interviewing is actually the missing link there. I've got a question on this challenge study. So I think I know the answer, but it seems like recruitment and then being told don't be active. I mean, I guess I wouldn't sign up for the option because I'd be like, no, but are these folks that are like, oh, cool. Or is it the opposite? Is it oh, good, I got in the non-active group? I don't know. Exercise is just something I love so much that I'm like, nah, but what have you seen, or what are you seeing, or what are you expecting to see, since it's just getting rolling with that random assignment to not a placebo drug, but don't be active. Don't be significantly active.
Yeah. So that's a great question. And so the way the trial is pitched is sort of maintain your usual lifestyle. Here's the information. So you get all the information, health pamphlets, like kind of standard of care, like you should move more. Or you get a structured 3-year exercise intervention. It's mostly physical activity engagement. So increasing your physical activity level 10 Met hours above what you were doing previously, okay. But you have a coach. So you have in-person sessions for the first year, and then you move to kind of more behavioral counseling, which can be in-person or virtual from there. So you have someone supporting you through that journey. So everyone's told to sort of, here, exercise is probably good. But what we know from research generally, that unless you have that coach really facilitating you, like a pamphlet only goes so far. Right. And so that's the difference. That being said, you're probably not going to sign up for it because if you like activity and this is an international trial. So it's based in Canada, but it has sites in Australia and other countries around the world, even the US. And what we see is site-by-site differences. Vancouver, where I'm based at the University of British Columbia, is a very active place. Activity is kind of part of a lot of people's lives. So when the oncologist said they pitched the trial, people were like, oh, exercise is good for me. I'm just going to go get a personal trainer or talk to my friend who goes on hikes and I'm just going to go with them. Like that's the end of the discussion. On the flip side, other parts of the country, it's like pulling teeth, like the potential to be randomized to the exercise arm is something people's like worst nightmare. And so it's the whole range. And so I think we're going to have a range of people where activity was kind of something they were interested in or willing to do. Some that were like, maybe if I got into it, I'd still try. So, but we don't have, the two ends of the spectrum probably.
So that leads into a related question. The word exercise, you and I are like, yay. But for a lot of people, it's kind of like, is there value in using the word that you mentioned before, move, or just active? Have you seen differences with that? Have you played with that at all? Are your coaches or your exercise physiologists doing anything like that? It just, I don't know. You know what I mean? You're a physical therapist as well. Our patients come in and you're like, okay, let's exercise. And they're like, no. Any tips along those lines with that word?
Okay. This is something I spent so much time thinking about recently because I feel like, are we offering people things they don't want? Like, how do we get people that are not just the ones who are kind of in that contemplation phase or like that kind of maintenance phase if we're looking at stage of change? Because that's who we do see in our trials, and that's been beneficial to show it's safe and get the right dosing, but is not generalizable. I think we've also spent a lot of time in trying to think about what's the forward-facing messaging. So that's why for that exercise guideline that came out in 2019, we did have move more as a starting point, and then talked about, what exercise was and, kind of dosing around that to sort of help the conversation. Like, this is good. And then if you're more interested, we can get you more specific. But I think you're entirely right. And I went to a talk recently where someone was talking about mindfulness, and it was mostly around caregiver burnout and healthcare provider burnout. But I think the point was well taken, that mindfulness wasn't a fit for working with, say, I think the military was police services was where this person had been brought in to try and help with kind of like this burnout thing. And then so mindfulness has been shown with evidence that it helps, but it was just not a fit. It did not resonate. So they changed the name. And this is the most brilliant thing. If you and I can solve it on this podcast, I want to do it. Tactical breathing.
Okay.
When it was tactical breathing, it was the exact same instructions. You got a little book, you had an eye mask, you had earplugs, and it was like the same box breathing that was done in mindfulness, but now it was tactical breathing. And everyone was all in for tactical breathing. That fit with kind of what their mindset was and how they kind of saw the world. And so if it was tactical breathing, they were up for it. If it was mindfulness, they were not signing up. And so what is for whether it's cancer or another chronic condition or just kind of therapeutic exercise, what is the tactical breathing of that? Is it remedial movement? Is it movement therapy? Like these things all, like, I'm just like, ugh, no, it's not good. That's not good. Like, but what can we use for move? Because I think honestly, that was a real illumination for me that we need to do a better job of meeting people where they're at. And if fundamentally we want people to move, what can we tell them that is more palatable? Because I agree with you, exercise has all these connotations of like gyms and spandex and instructors, or a lot of barriers. Like I need all these shoes and equipment and all the stuff. Physical activity, I think, is a better mix for sure. But then we just get ourselves tied in a knot because we're trying to talk about it with each other or put it into grants or put it into papers. And then, people are like, well, why'd you call it physical activity here and exercise over there? I mean, we're our own worst enemies on this a little bit too.
Right.
So I'm very curious about that and how we get that messaging right. And I think we need to work with like the people, the social scientists that do communication to come up with the move of the tactical breathing for exercise for chronic conditions.
It's such a great point. So one of the things that we do with our company is Catalyst to Lead is for high performers. So your executives, your athletes, your new employees, where they see a lot of potential in that person and they're like, hey, let's get them with one of the elite coaches with Catalyst. And it's so funny because these individuals, when you talk to them about what we said before, move, fuel, rest, connect, they're like, yeah. But what's the real secret? Kind of like, I'll sleep when I'm dead. Thanks, coach. But what can you really help me with? And when we presented in the research, my PhD focused on functional mental toughness. So what allows an individual to have mental toughness in a practical way, not the David Goggins, bite your lower lip and move forward, but what are things you can do on a daily basis? And when those high performers tune in to the research showing that if we can improve your sleep a little bit, if we can improve your fueling, these basics, instead of a throwaway, whatever, when they realize, oh, wait, my mental toughness will be higher when I do these things. Oh, let's talk. Like, tell me more, coach. I want to know. So it's exactly what you're talking about. I love the tactical breathing. I wrote down physical flow. I think I avoid the word workout because it has work in it. Exercise sounds negative in itself, so I'll do some brainstorming with that too. And let me know what you find out with your wordsmithers, because I love that concept. And there's something, a breakthrough there is going to help people, in a lot of areas. Your research has shown that exercise can help manage the side effects of cancer treatment, fatigue, neuropathy. What are some of the key biological mechanisms that create this, that produce these types of benefits? Because that might click in the why for some of the folks going through that journey. And by the way, folks, don't pass this along to somebody so they feel guilty for one more thing. But this can be a great resource because maybe that person does tune into this will help my neuropathy. Well, that's really important to me. So I'm interested. So can you walk us through some of those elements?
Yeah, the physiology, I mean, the fundamental will go with cancer-related fatigue, for example, or, just physical function, like being able to do, we measure like 6-minute walk test or a 30-second chair stand or things like that. So fundamentally, what is happening with a lot of these cancer treatments, so we'll use chemotherapy for an example. Typically what's happening is the insult on your body, like all the things we know that help to maintain good cardiovascular function. So cardiac output, good blood volume, all the mitochondria in your muscles taking up oxygen. Those things are all insulted by chemotherapy. Yes. Chemotherapy is a systemic therapy that interacts with all the cells in the body. It's targeting fast growing cells, but it has kind of systemic impacts. So for fatigue, a lot of it is anemia, so low red blood cells. And if it even goes back to their exercise physiology, oxygen carrying capacity of blood, if you have lower hemoglobin levels, then already you're having a decreased oxygen carrying capacity. So all of that translates into poorer cardiovascular and whole body exercise function. What we're trying to do with adding exercise back into the mix is the same training effect. So trying to get productive functional overload of all of those things to try and maintain. When we try and publish our studies, everyone, of course, with an exercise program wants to see an improvement over time in VO2 max, 6-minute walk test, whatever else. For a lot of our research, if we can maintain where people started
100%.
from,
absolutely.
Huge, because what's consistently seen in the research is that people's physical function drops like a stone, and for all the reasons, and so that's what we're trying to do. We're trying to balance off that. And a lot of the interesting thing that's happening with the research piece that we're looking at, the whole, cardiovascular system, is that a lot of the changes are peripheral. So how do we try and maintain mitochondrial number and size? How do we try and maintain good angiogenesis and vascularization of those tissues? And it's exercise. That's what drives some of that. The central things like, cardiac output is a little bit challenging because people get a bit dehydrated. We see changes in heart rates and blood pressures as a result. So people are pretty consistently have sort of lower blood pressure. And as a result, to try and maintain your cardiac output, back to class here, what do? Heart rate has to go up. So people have sort of resting tachycardia consistently. So some of that central stuff is a little bit hard to manage just because it's kind of the big picture stuff, but it's all that peripheral stuff where we think a lot of the benefits are happening. Really nice work from Sweden. Where they actually took the Karolinska Institute, because Scandinavians do this, they took muscle biopsies, and they really showed that the benefit of the activity that they were planning, which had some HIIT and things like that in it as well, was at the periphery. And some of the nice changes that you would expect to see with exercise, they were still seeing that benefit. So that's kind of some of the physiology. The peripheral neuropathy is really interesting. And I think the jury's still out. We're kind of coming up, maybe potentially it helps. But again, these are small nerves in that typically hands and feet is where this kind of mostly manifests. And so again, there's some better improvements in potentially blood flow or potentially better circulation. So the drugs maybe are being metabolized slightly differently. So there's those sort of things that are being thought of. But fundamentally, like fatigue and physical function, it's just how do you maintain kind of all the systems for cardiovascular fitness that you normally would have with exercise, for example.
Okay, so it's almost bringing, if the general trend is, hey, my life, I'm used to being an 8, with chemo I go 7, 6, 5, 4, 3. Maybe it allows that to come up one notch, so it makes it a 7, 7, 6, 6, 5, something along those lines.
Yeah, along those. And if someone hasn't been active beforehand, I'm not saying that you could see a potential improvement. And, there is some studies where they've actually shown slight increases in VO2, for example, adding structured exercise to someone that hasn't done it before. Strength is huge too. I mean, we see huge strength gains. And I think especially in our studies in women who have had breast cancer, they are pretty resistance training naive. And so we're adding volume onto that. And people are like, wow, I am so much stronger even during chemotherapy because they just haven't done it much before.
That's interesting. And did I ask you, I may have asked you this during your seminar, HRV, we've had a couple of lectures on that are really doing a lot of work with HRV, and it's fascinating to me. Is that something you've pulled in? It seems like that could be a nice overarching progression measurement that you could be using and they could be using on a daily basis. Is that part of some of the things you're doing right now?
So I haven't done much in that space previously. And so there are some people that are very focused on the cardiovascular effects of chemotherapy or other treatments and trying to understand that. So I am not as well versed in that, but I think there's a lot of interest in it. And I think some of the challenges early on were just the variability and the measurement of it was, we didn't have the best tools that really were that functional. But I think as we've had an improvement in a lot of the wearables and sensors, I think a lot more of that will be coming online. I think it's one of those things like, how complicated do we make this? And I think for someone that's really interested and previously did a lot of activity and is used to using all the different insert whatever sensors, like all the professional golfers have their ring and things that they use, that's the person that, sure, if they can connect with someone that has an exercise background, has some understanding of cancer, you can probably do a lot with that and try to understand the good days, bad days, more than just like, how are you feeling, which is how we've used it. So I think there's an opportunity for that. It just hasn't been used as much in the research because it's kind of been more complicated. But I think there's a lot of interest in that.
100% agree. And we have no connection with Marco Alatino, except he was a guest on the show. But the HRV4, the number 4 training app, I found answered that question because I felt exactly when we had our first couple of interviews with folks that were studying this, I was fascinated. I'm like, yeah. And then, so I have to get up each morning, put on a cold heart rate strap, try not to jump off the chair, and then measure. Like, it was such a pain. Even for me, when I cared about it, I gave up after a month. But Marco's thing is literally your iPhone for 60 seconds. With your finger.
Yeah.
So there's no equipment, there's nothing. And so I don't know. That's something.
Yeah. And how accurate are those things? And like, how do we, and what's the research behind them? And I think that's where I dipped my toe in 10 years ago and was like, it seems like there's a lot of variability here. And for what I'm trying to do, which is just like, how do we get people moving and I wasn't needing that approach. But I think with more wearables, I think there's a lot of opportunity going forward.
I will try to make a note to connect the two of you for conversations. So for the person who's listening in the midst of treatment for cancer might feel like, oh, great. Like, now you want me to do one more thing. I've got this stressor. I'm dealing with my life. Everyone's giving me advice. I'm exhausted. And now you want me to exercise? Like, how do you approach that? Because it seems like cancer in and of itself is so overwhelming for the individual and for every single person in their circle of relationships. And now we're saying, one more thing. What do we do with that?
It's really tough. And I think that's where what we've seen from the research is that if the oncologist is a champion, they will endorse it. And that endorsement is huge because as much like that, two people are looking to as a trusted source of information. And so I think we've just worked a lot with trying to give the oncology team like an easy opportunity. So part of the 2019 guidelines, there was a accompanying paper that came out that was like, how do we get the oncology care team kind of part of the solution? And so it is like the basic stuff like ask, advise, refer. And so, hey, are you, engaging in regular physical activity, breathing hard, like all those sort of key questions, yes or no. If not, then, hey, do you know that exercise might be beneficial? And again, we should be talking more about like moving more might be beneficial and help you manage the symptoms. And then if not, hey, let's connect you to what programming's available. That's the piece. The refer is the big challenge because there's not a lot of services. And so the oncologists, when we talk to them, they're like, yes, we've seen that exercise can be beneficial for our patients. They seem to feel better. They seem to manage treatment better generally. But at the end of the day, there's so much for us to talk about in an oncology session in terms of making treatment decisions. I'm not really an exercise person, so I don't know what to tell people other than like maybe try walking.
Exactly.
And there's nowhere to refer them to. And so I think that's why a lot of the focus is like, how do we get a system in place so it's easy to refer people either within the cancer system or, through moving more with cancer, which is an ACSM initiative of just having one place that they can just send people to for high quality evidence-informed information that can get people to community programs. So that's kind of the oncology piece. Talking to an individual person, again, there's so much going on. And so, I think it's like just providing the information that exercise might be beneficial or moving more. And hey, it doesn't have to be complicated and, just trying it out and seeing if it's of benefit. And I think the nice thing about potentially programming, if you can find something in your community, and there are different programs around the country, which you can find on Moving Through Cancer, I think it's called. I'll get you the website for Perfect. The podcast. It's just being able to talk to someone like, is this normal? Like, I'm feeling like this when I go for a walk. Like, is this normal? And talking to other people that have kind of been through the same diagnosis. The one thing we see with all of our trials where we have supervised activity is we think, of course, people want to come and exercise or be, they don't really. They want to come to the treadmill and talk to their friend who's going through the same thing they met through the trial, because there's so much sharing of social support. Really technical, like important stuff like, where do you find the wig, right. Like, bra, things like that, all the way down to like different treatment types, so like what someone's told you about this, like all that sharing, and being in a space where the other people are going through the same thing. Family members are well-meaning, everyone wants to help or try, but they're not going through the same thing. And I think that space where you can just talk to people very candidly about what's going on for you has been really a huge part of getting people together in those kind of groups. And support groups, which are talking groups, can do that. But I think for a lot of people, the activity piece and having something else to do that kind of, it's you can talk if you want to, you don't have to, has really been beneficial for people. So I really encourage people to try and find opportunities that kind of bring you to with other people who are kind of going through something similar to maybe help you in your activity journey.
And that brings up something we spoke briefly about offline. I've reached out to some folks that have recently gone through the journey and just asked, were you set, did you get any guidance on the value of exercise or increasing movement? And the general answer was, the doc might have said something about try to be active through this, but that was it. And again, I know the world I live in. I get it. This is important to me, and same with you. I mean, you're a fellow of the American College of Sports Medicine, for goodness sakes. But how do we get this out to the docs in at least because you're right. When a physician suggests X, the data tells us your likelihood of doing X goes up, not 100%, but it's high. How do we get that out to the docs?
This is I said just, every conversation I have, I feel like at ACSM last week was this exact question. Like, we know exercise is good. We have a prescription, we got guidelines, but at the end of the day, how do we get people to do it? I think one piece I think about a lot is we have a ready workforce. There is kinesiology grads or exercise science or whatever you want to call it, your program. There are so many. And yes, they are great places to go for pre-medicine and pre-PT and all these sort of things. But these people have excellent skills that are being underutilized. And so how do we just give the doc the key information, just ask advisor for, hey, tell people activity is good. And hey, here's where you send them that's high quality, evidence informed, and you can feel confident in. And that's a huge gap. So knowing that's a gap, we are working on that. I think the other piece is doing high quality research. And so that's what we've also been focusing on. Research that shows changes in chemotherapy completion rate, large randomized trials where it has some endpoints that are really impactful for them. There's a really nice trial that's just being presented kind of at the main meetings right now called Preferable 2. It was a European Union intervention. It was individualized health coaching for women with metastatic breast cancer. And they have really nice impacts on, health, cost savings, physical function, quality of life, really 700-person trials. So I think we're trying to bring the level of evidence that they are used to seeing to some of the work to really, just convince them. And then at the end of the day, so I want them to use the workforce that's there, make it easy for them. I think we need to meet some of the evidence that's there. And I think what I really focus on too is that there's a lot of equity issues here. If a physician tells you and you're an exercise person and you have, unlimited resources or good health finding literacy skills, they'll tell you exercise isn't beneficial. Great, I'm going to go get a coach. I'm ready to go. Off I go. The challenge for me is that for a lot of people, that's not their reality. They are going to go and seek that out. So how do we make it easy for them to access programming that's free, that's a fit for them, whether it's virtual or in person at a local community center or someplace that makes it easy for them to even take that advice. And I think that's another big gap we have right now that I would like to find a solution for.
Yeah. All right, we'll keep working on it. Let's talk cancer survivors. What are some of the long-term impacts of an active lifestyle, both physically and psychologically? And how can exercise help promote overall quality of life and maybe even reduce recurrence post-treatment? So this is a person that's been through it. You're never done, but we're in that next phase at least. What role does exercise play there? What are some promising discoveries in that arena?
Yeah, so I think there's really consistent observational evidence that being more active after your cancer diagnosis does decrease the risk of cancer recurrence, death from a cancer, as well as that all-cause mortality. So just one of the main things with early stage cancers like breast cancer, prostate cancer, cardiovascular disease is actually the leading cause of death for most of these people. It's not the cancer themselves. Yeah.
Interesting.
So, the treatments have a big impact on the cardiovascular system, negative potentially, and then people are less active during diagnosis or maybe afterwards. So those are the things I think, why we really talk about just exercise for general health. I think there's a lot of interest in understanding what the mechanisms of that are. So a lot of it with activity is things like changing inflammatory markers, changing handling of metabolic factors like insulin handling, glucose, those things that all kind of have been linked to the risk of cancer, and then we're helping to improve that kind of the milieu around potential small metastases. We're changing that kind of ability for them to grow potentially by being active. So kind of taking away some of those growth stimulation ideas is kind of the thought process with it. Changing blood flow, I think, is a huge thought, especially exercise during treatment. Are we able to deliver more chemotherapy to the tumor if you're more active around the time of chemotherapy? So a lot of that work is being done in animal work. Some really cool work in spaces where there's opportunities to get a biopsy when someone's diagnosed, and then give them some exercise before they have their definitive cancer surgery. So that's a really neat space, so they can get human tissue before and after. And if you can look at the effects of exercise during that to understand what the biology is there. A really nice study that came out just this past year in early stage breast cancer. And they basically showed in the people that had exercise from the time of biopsy when they were diagnosed to when they had their definitive surgery, some people actually receive chemotherapy during that time. It's called neoadjuvant chemotherapy, and sometimes it's used to shrink the tumor so it's easier to take out versus taking the tumor out first and then giving the chemotherapy. And the interesting thing with that is they actually had more of a pathological complete response. So the tumor responded better to the chemotherapy in the people that exercised versus didn't. And so that is super exciting because that really is trying to, yes, we see this on an observational level, but now we're kind of understanding the biology and really being able to kind of pinpoint some of the things that are happening in the tumor itself. Wow. So that's cool. And that prehab space where before you have your cancer surgeries. The other piece, obviously, is that after the cancer surgeries and some of the treatment, what the whole point of the kind of risk of recurrence is maybe micrometastases, so little bits of the tumor have gone into the circulation, blood or lymph, and kind of seeded somewhere else. And that's where this exercise potentially might be making it a poorer kind of soil environment for seed and soil kind of thought processes. If they're going to other parts of the body, they may not be as likely to grow and seed in there. So those are kind of the ideas. Yeah.
Wow. All right. I've covered everything I wanted to cover, but you're always fiddling with stuff. So is there anything that you're like, oh, Brad, I've got to share this? Throw it out there. Anything that is fascinating to you right now you think our listeners might enjoy?
Yeah, I think one of the challenging things is sometimes activity, people that have bone metastases. So sometimes the cancer itself, if it metastasizes, it can go to the bone. That's a common place it goes to. Sure. And it's things like the long bone of the femur, the pelvis, the spine, places when you think of as an exercise professional, you're going to be loading with most of the activities we do, a squat, getting out of the chair. I mean, these are loading all those areas. It makes it really challenging to prescribe exercise. But on the flip side, these individuals have now an advanced cancer. The cancer has spread to somewhere else, but we know now with the advances in treatment, people are living with advanced cancers for much longer than they ever did in the past. So they have 5-10 years. And so the question is I want to maintain activities I'd like to do, golf or tennis, Or I want to at least maintain my function because I know I have advanced cancer. I'm having serial lines of treatment to try and manage that. I'm getting all the side effects, but of all the treatments, but more and more because I'm having more and more treatment. I want to keep moving. I want to keep functional. I want to keep independent. So there's a real tension around how do we prescribe exercise safely? And so what we've done is we have exercise recommendations we published in 2022 that try and give some guidance to people living with bone metastases, the healthcare team, as well as the exercise professionals, the PTs, and the exercise physiologists on how to try and manage this. And we've just developed some knowledge products, which is basically patient education handouts and webinars. That's the fancy term.
I like your phrase better. Yeah.
Yeah. Knowledge mobilization products. And so we just launched those at ACSM this year, so last week. And if you're interested in that, it's the easiest way to find it is go to our bit.ly. So it's bit.ly/capital letters BME and then capital HUB. So BME Hub, but you got to use capital. For the first part of the BME, and then the hub has some other ones. And I'll get that link to you, but that's where we have a patient handout. We have webinars on how to manage this. We have a health information form that tries to help with the sharing of information between my oncology team and the exercise professional. We're going to have some professional development tools for that. So leaning into the space where we know exercise prescription is even more challenging and guidance for people is even more complicated. How do we as kind of exercise professionals kind of lead and provide resources? So that's kind of the most exciting thing we're looking at right now. So I hope people will visit it and hope they find the tools useful.
Love it. And we will have a link to that, everybody, in the description so you can access that easily. And did you just give me the word or the phrase that you were looking for earlier? What if you went with strategic mobility for your patients?
Oh, strategic mobility. I love it.
Okay. Well, we just changed the world, everyone. That's right. Exactly. Dr. Campbell, this is awesome. Super, super important work you're doing. Thank you. Thank you. Thank you. It's so interesting because you and I are both physical therapists by background, but what we're doing and what we've been doing is so different and yet pulls in that key component from our history. So thanks for doing this. Really appreciate it. And we will definitely keep up to date on what you're doing.
Yeah, thank you so much. It's been great talking to you.
Thank you, Kristin. As I mentioned early on, I have a feeling this is one of those you're going to be passing on to family and friends. If you're an employer, EAP, or wellness service provider looking to move beyond generic coaching for employees or those you serve, Catalyst Coaching 360 has been the best-in-class leader since 2007. In addition, you can now access a range of specialty coaching options, including tobacco cessation, pre- and post-surgical outcomes, and high-performance coaching for executives, managers, athletes, and others. All the details at catalystcoaching360.com, or please reach out anytime. Results at catalystcoaching360.com. And now, it's time to be a catalyst. This is Catalyst Coaching 360's Dr. Brad Cooper. Make it a great rest of your week, and I'll speak with you soon on the next episode of the Catalyst 360 podcast, or maybe over on the YouTube coaching channel.